Okay, I want you to picture a stadium, a massive, Super Bowl-sized stadium.
Right.
Now, fill every single seat. And then imagine you have to fill, I don't know, about 300 more of those stadiums. That is the scale of the crowd we're talking about today.
Which brings us to roughly, what, 25 million people?
25 million. That's the number of adults just in the United States living with chronic venous disease. And I think for a lot of us, when we hear vein problems,
Yeah.
the brain just immediately goes to, like, the cosmetic aisle.
Sure, spider veins.
Yeah, we think, oh, I have a few spider veins, I'll wear long pants.
Yeah.
But the source material we're digging into today shows this is so much more than a vanity issue.
Absolutely. We're talking about a condition that operates on this massive spectrum. I mean, it ranges from your legs just feeling a little heavy or swollen
After a long day.
for a long day, all the way to debilitating venous ulcers. We're talking open wounds on the leg that just will not heal. It is a massive medical burden. In fact, if you look at the data, venous leg ulcers alone cost the payer system about $14.9 billion annually.
14.9 billion. I mean, that is not small change. That's a budget-breaking number.
It really is.
So to help us navigate this massive landscape, we are doing a deep dive into a brand new heavyweight document. We're looking at the 2025 SKI Clinical Practice Guidelines for the Management of Chronic Venous Disease.
And SKII is the Society for Cardiovascular Angiography and Interventions. So this isn't, a blog post. This is the gold standard.
Yeah.
They've pulled together the top experts in the field to rigorously review all the evidence, what works, what doesn't, and importantly, where the medical community needs to stop guessing.
And what I love about this report is that it really feels like a turning point.
Yeah.
It feels like we're moving away from that old school, just wear some tight socks and live with it approach. To some really high-tech precision medicine.
That's the perfect way to put it. It represents this fundamental shift toward what we call shared decision-making. You see that phrase pop up constantly in these guidelines.
Okay.
It's no longer the doctor just telling you what to do. It's about matching the treatment to your specific anatomy and, crucially, your specific life goals.
So let's get into the landscape here. We've established the scale 25 million people. But before we get to the treatments, there's a specific kind of nerdy detail in these guidelines I have to ask you about.
I think I know which one you mean.
It seems small, but you flagged it as a big deal. They actually renamed a vein.
They did. And it sounds like semantic housekeeping, but it's actually quite significant clinically.
Sure.
There's a vein running down the front of the thigh. It used to be called the anterior accessory great saphenous vein.
Which, to be fair, sounds like an optional accessory. Like a scarf.
Exactly. Or a spare tire you don't really need. It sounds like a side road. But anatomically, this vein sits in its own fascial compartment. It's a significant vessel.
So it's not an accessory at all.
Not at all. So these guidelines, they've officially dropped the word accessory. It's now just the anterior saphenous vein.
So it got a promotion.
It got a promotion to truncal vein status. And that matters because, in the world of insurance protocols and clinical algorithms, truncal veins get treated differently than tributary veins.
Oh, okay.
By recognizing it as a major highway for blood flow, not just a side street, it changes how aggressively we can treat it. It validates that this vein is a major player.
Okay, so the map has changed a bit. Now, let's talk about the rules of the road. One thing that stood out to me is how they classify their advice. They use this system called GRADE.
Right. And for anyone trying to decipher medical guidelines, GRADE is basically your decoder ring. You're going to see two main flags: strong recommendations and conditional recommendations.
Okay, break that down for us, because conditional sounds a little wishy-washy.
It can feel that way, but it's actually all about nuance. A strong recommendation means the evidence is really solid. The benefits clearly outweigh the risks, and honestly, almost every well-informed patient in that situation would want that treatment.
So that's the just do this, it works category.
Precisely. It's the kind of thing that can easily become hospital policy.
And conditional.
Conditional recommendation is where the art of medicine really comes in. It means that while the treatment is likely beneficial, maybe the evidence is lower quality or the trade-offs are significant.
So different choices for different people.
Exactly. It implies that different choices are appropriate for different patients, and that's where that shared decision-making becomes mandatory.
Right.
The doctor needs to sit down with you and say, here are the options. Based on your values, whether you hate surgery or you hate wearing compression stockings or you want the fastest fix possible, what do you prefer?
Speaking of things people hate wearing, Let's talk about compression therapy,
Mm.
the dreaded stockings.
The cornerstone of conservative care. Or at least, it used to be the blanket answer for everything.
And the 2025 guidelines, they create a really fascinating divide here.
They do.
I noticed they treat varicose veins very differently from venous ulcers when it comes to compression.
Very differently. Let's start with symptomatic varicose veins. So you have bulging veins, maybe some swelling, some heaviness.
Right.
The guidelines give compression a conditional recommendation here with very low certainty of evidence.
Very low certainty. That's
Yes.
that's surprising. I thought compression was the holy grail.
It definitely helps with symptoms. I mean, if you put them on, your legs will likely feel less heavy, have less edema. But the conditional part is huge.
Okay.
The guidelines explicitly say some patients might value a rapid resolution of symptoms. They might not want to wrestle with tight stockings every morning for the rest of their lives.
So if I walk in and say, look, I am not wearing those socks, the guidelines basically support me saying, okay, let's look at fixing the vein instead.
Effectively, yes. They shouldn't force you to fail conservative therapy if your goal is to fix the anatomical problem. But, and this is a massive pivot, if you have a venous ulcer, the script flips completely.
Right. For ulcers, it says strong recommendation.
Strong recommendation, moderate certainty. If you have an open sore on your leg from venous disease, you need compression. The data is clear. It significantly increases the rate of healing. It's not really a choice if your goal is to close that wound.
But there's real friction here, isn't there? The guidelines have this section called remarks, where they get surprisingly real about the difficulty.
It's the real world section. They acknowledge that adherence is, well, it's terrible.
Yeah.
These stockings are incredibly tight. That's how they work. But if you have arthritis in your hands, if you're obese, if you have back problems, the act of donning and doffing
Putting them on and taking them off.
can be physically impossible.
And then there's the money aspect. This part made me want to pull my hair out.
The insurance gap.
Yes. The guidelines explicitly call this out. Medicare and insurers will pay thousands for a high-tech surgery to close a vein. But they often won't cover the compression stockings or the devices that help you put them on.
It's a massive disconnect. We have a $14.9 billion ulcer problem, and we're putting up financial barriers to the most basic effective tool we have to prevent them.
It's misaligned.
Totally. The guidelines actually urge payers to cover these donning devices to improve access. It's a clear statement that the system is broken.
Let's hope someone at an insurance company is listening to this deep dive. Okay, let's move from the conservative stuff to interventions, when the stockings aren't enough.
Or we don't want to wear them.
Right.
Yeah.
We start looking at shutting these veins down. The plumbing fixes.
The plumbing fixes, exactly.
The big one seems to be ablation, thermal ablation,
Yeah.
basically using heat to close the great saphenous vein.
This has really replaced the old vein stripping surgeries. It's minimally invasive. You insert a catheter, use radiofrequency or laser, and seal the vein shut from the inside.
But I've heard this objection before, and the guidelines address it. The save the vein debate.
Ah, yes.
Hey, what if I need a heart bypass in 10 years? Don't I need that leg vein?
It's a very common question, and it's a valid logical leap. But here's the reality check from the guidelines. If your saphenous vein is dilated, refluxing, and diseased enough to need ablation,
It's not a good vein anymore.
it's a terrible candidate for a heart bypass conduit.
So you're saving a rusty, leaking pipe, hoping to use it for high-pressure plumbing later.
That's a perfect analogy. A dilated varicose vein just won't work well as a coronary graft. So the guidelines say the presence of a diseased vein shouldn't stop you from getting treatment. That vein has already failed.
Okay, that makes sense. Now, heat isn't the only way to close a vein. There's also non-thermal ablation. Why would I choose that?
The main reason is nerve injury.
Okay.
The saphenous vein runs right next to the saphenous nerve, especially as you go down the leg below the knee.
So you could damage it with the heat?
You could. If you use high heat in that lower segment, you risk damaging the nerve, which can leave you with permanent numbness or tingling.
So below the knee, we might want to use, glue or chemicals instead of heat?
Precisely. The guidelines mention that non-thermal modalities like cyanoacrylate glue or mechanochemical ablation might be preferred in those areas to avoid that thermal injury. It's about anatomy dictating the tool.
Speaking of chemicals, let's talk about sclerotherapy. This is the foam, right?
Yes.
Mhm.
You inject a foam into the vein that irritates the lining and causes it to close off. It's great for tortuous veins, the really twisty ones where you can't shove a straight catheter.
But there were two specific warnings here that caught my eye. One was cosmetic and one was frankly, a bit terrifying.
Let's do the cosmetic one first. Hyperpigmentation.
The brown staining.
Right. Sclerotherapy can leave a brown stain on the skin where the vein was. The iron from the blood gets trapped, and the guidelines warn this can be permanent.
So if your goal is purely cosmetic,
You need to know you might trade a blue bulge for a brown line, which brings us back to shared decision-making.
it always does. Okay, now the neurological warning. This involves something called a PFO.
A patent foramen oval. It's a small hole between the upper chambers of the heart that about 25% of the population has.
And usually it's not a problem.
Usually not, but when you inject foam, you're injecting microbubbles. If those bubbles travel up to the heart and cross through that hole,
It'd go to the brain.
they can go straight to the brain instead of being filtered by the lungs.
Yeah.
And bubbles in the brain sound bad.
Yeah.
It can cause visual disturbances, migraines, or in very rare cases, transient stroke-like symptoms. It's why technique and patient selection are so important.
Okay, so foam has its risks. What about just ripping the veins out? Phlebectomy.
It sounds barbaric, ambulatory phlebectomy, but it's actually very elegant. Small punctures using a little hook to physically remove the lumpy tributary veins.
And the stats on this were really impressive compared to the foam.
Very. For those specific lumpy veins, the recurrence rate at 1 year was only 2.1% for phlebectomy.
Wow. And for sclerotherapy,
It was 25%.
45%. So 1 in 4 people had the veins come back with the foam, but almost no one did with the physical removal.
Which is why, for those specific lumpy veins, the physical removal often wins out in terms of durability.
Okay, so we've covered the surface veins, the ones we can see, but this is a deep dive, so we have to go deeper, literally. Let's talk about the deep venous system.
The iliac veins in the pelvis, this is where the stakes get higher. We're talking about the main drainage pipes from the legs back to the heart.
And sometimes these get blocked.
Compressed or narrowed, severe, deep venous stenosis.
And the fix here is stenting, putting a metal scaffold in the vein to hold it open. But the guidelines are very specific about how you do this.
Oh, yes. You cannot just guess. You can't rely on a 2D X-ray, what we call venography. The guidelines heavily emphasize the use of IVUS.
Intravascular ultrasound. That's a camera inside the vein.
Essentially, yeah. It uses sound waves from inside the vessel to see the exact diameter. Because if you get the sizing wrong in the deep veins, the consequences are disastrous.
This brings us to the devastating complication mentioned in the text, stent migration.
It's the nightmare scenario. If a stent is undersized or too short, it can dislodge. And because the blood is flowing toward the heart and lungs,
That's where it goes.
that is exactly where the stent goes. It can migrate into heart chambers or the pulmonary arteries.
And that requires open heart surgery to fix.
It does. It is rare, but the guidelines highlight it to emphasize why IVUS and proper sizing are absolutely non-negotiable.
It really highlights that while this is a vein procedure, it is not minor surgery. This is high stakes.
Not at all.
Now, one thing I appreciated about this document was their honesty about what they don't know. The knowledge gaps.
Right. Science is always a work in progress, and they identified a few big black holes where the evidence just isn't there yet.
The femoral veins were one.
Right. We talked about stenting the iliac veins up in the pelvis, but for the femoral veins down in the thigh, the guidelines say no recommendation.
So we just don't know if it helps.
We just don't have enough evidence to say if stenting or ballooning them helps long term. We need more research before we start putting metal stents in the thigh where there's so much movement.
Okay, what else?
Another big gap was perforator veins. These are the connectors between the surface and the deep systems. We know we should treat them if there's an ulcer nearby.
It helps healing.
It helps healing, that's established. But if you have a bad perforator vein and no ulcer, just symptoms, the panel said, we don't know. They made no recommendation.
That's a really important takeaway. It helps protect you from potentially unnecessary procedures.
Absolutely. It protects patients from overtreatment.
So let's unpack all this. We've gone from the renaming of a vein to the intricacies of stent migration. If you had to synthesize the so what of the 2025 guidelines, what is it?
I think the big shift is it's precision and personalization. We are moving away from a one-size-fits-all approach.
Where everyone just gets stockings.
Right. Or everyone gets their saphenous vein strip. Now it's about matching the tool to the problem.
Right.
If you have an ulcer, we're aggressive compression, ablation. If you just have varicose veins, we have a conversation. What are your goals? Do you want cosmetics? Do you want symptom relief? Are you willing to wear stockings?
It empowers the patient.
It empowers the physician and the patient to build a plan that actually fits. It's a huge step forward.
And it validates that this is a serious disease. It's not just ugly legs. It's about preventing that $15 billion burden of ulcers.
Exactly. It elevates the standard of care for millions.
I want to leave everyone with a final thought that has been nagging me since we started. We have this incredibly sophisticated medical document about how to use lasers and foams and stents. And yet the one thing that we know for a fact heals ulcers compression is the one thing that's hardest for patients to get covered by insurance.
It's the paradox of modern healthcare, isn't it? We'll pay for the cure, but we struggle to pay for the prevention and the care.
Something to think about. Next time you look down at your legs, there's a whole complex highway system down there. And thanks to these guidelines, we have a better map than ever before.
We certainly do.
Thanks for listening to this deep dive. Take care of your pipes, everyone.
See you next time.